I would start by welcoming everyone to this symposium. At last year's conference in Montreal, a group of people at the Methods Development and Economic Evaluation Interest Group decided to put forward a suggestion for a symposium for this year's meeting. And we had a few good suggestions, but to discuss the choice of perspective was the theme that we decided would be best fit for this conference, given the overall theme of many views on value. Before I introduce the panelists, I would make you aware of that this session is live streamed, and also of these values and expectations that we have decided for SMDM. So I will just read them so you can have these in mind. We demonstrate respect for others through clarity and brevity in our interactions with oral presenters. We acknowledge the value of work even as we identify concerns or flaws. We believe that criticism should always be constructive, balanced, and actionable. We always provide criticism with the goal of making the work better. Yes. And here is a list of the authors. First, Natalia Kunz would make the introduction of the choice of perspective, and then David Kim would talk about the second panel and the analyst perspective. Scott Gross would go into methodological issues, and Yao Xuan Chen will talk about the multi-criteria decision analysis. But the session is not only about them, it's also about you. So in the end, we hope to get fruitful discussion about the topic of choice of perspective. So then I introduce Natalia Kunz. Yes.
Perfect, yeah. Hi, I'm Natalia Kunst. I'm a PhD candidate at the University of Oslo and a research fellow at Yale School of Medicine. And I would like to start this with giving a brief overview of various recommendations for perspective in health economic evaluation. So in my agenda, I included both general non-governmental recommendations as well as governmental guidelines in a number of countries. And in this overview, I considered 5 non-governmental recommendations, and those are the second panel on cost effectiveness in health and medicine, the ISPUR Special Task Force, the textbook by Drummond et al. On the methods for economic evaluation, the International Decision Support Initiative, and the World Health Organization. I also reviewed 45 national guidelines based on a number of overviews that are available in the literature, including Valier et al., Collier et al., the INSPUR pharmacoeconomic guidelines around the world, and the guide to economic analysis. And I went through the national recommendations for economic evaluation methods and HTAs for the majority of the included countries. And here I would like to mention that I tried my best to find the most recent guidelines, and I hope that I succeeded with this, as that was not always the easiest task. So to start with, I would like to mention that a health economic evaluation can be performed from a number of different perspectives, including but not limited to health plan enrollee, technology manufacturer, patient, health plan manager, government regulations, provider, specialty society, and society as a whole. And here I distinguished 3 most commonly seen perspectives, and this is based on the literature, but also on the review that I performed. And those are a payer perspective, which includes the formal healthcare costs borne by third-party payers. Healthcare sector perspective, which include both the costs from a payer perspective as well as out-of-pocket costs paid by patients, and a societal perspective, which is the most generally inclusive, and this includes both direct and indirect costs, for example, productivity loss. So to start with general non-governmental guidelines, both the second panel and the ISPOR Special Task Force recommend using both societal and healthcare sector perspectives as two separate reference cases. And in addition, the ISPOR Special Task Force indicates that health economic evaluation from a perspective of any of the previously mentioned stakeholders could be informative and valid depending on the decision context. Next, the textbook by Drummond et al., as well as the International Decision Support Initiative, recommend using a multi-sectoral perspective, and they indicate that using this approach, the analyst can indicate or provide extensive information about the impact of the proposed investment on different sectors. And finally, the World Health Organization recommends using a societal perspective. So as we can see, all of these non-governmental guidelines recommend using a broader scope of analysis. And now moving to the national guidelines, we start with payer perspective. And this perspective, so 7 countries recommended using a payer perspective with a possibility of including supplementary analysis from a societal perspective. And those countries are Canada, Mexico, Croatia, Hungary, and Slovenia in Europe, South Africa in Africa, and Malaysia in Asia. In addition, 4 countries recommended only a payer perspective without mentioning that there could be a supplementary analysis from a societal perspective. And those are Czech Republic, Slovak Republic, Israel, and Russia. And in total, 24% of the reviewed countries recommended a payer perspective. When moving to healthcare sector perspective, 10 countries recommended using or recommend using a healthcare sector perspective with a possibility of supplementing the analysis from a societal perspective. And those countries are mainly located in Europe. Here, they include Latvia, Lithuania, and Estonia as Baltic states, England, France, Finland, Ireland, Poland, and I also include Norway here, as Norway recommends using so-called extended perspective, where they recommend, in addition to include time spent on treatment as well as travel costs, although travel costs are reimbursed in Norway. Additional 11 countries recommend only using healthcare sector perspective, and those countries are Argentina, Chile, Colombia, Paraguay, and Uruguay in the South America. In Europe, those are Belgium, Germany, Greece, and Scotland. And in Asia, we have also Singapore and New Zealand. So in total, as many as 48% of the reviewed countries recommend using a healthcare sector perspective. And now to the most inclusive perspective, societal perspective. Only 4 countries recommend using a societal perspective with a possibility of including a supplementary analysis from a healthcare sector perspective, and those are Austria, Italy, and the Netherlands, and Taiwan in Asia. And additional 6 countries recommend only a societal perspective. And these countries include Cuba, although here I would like to mention that the guidelines were quite old, from 2003, and I could not find anything more recent. Then VA in the US, Denmark, Portugal, Sweden in Europe, and Thailand in Asia. So in total, 22% of the reviewed countries recommended a societal perspective. In addition, I looked into the costs that were, or type of the costs that were recommended to be used as a part of societal perspective, and most of the countries were very broad in the terms. Of course, they mentioned indirect costs. Some countries mentioned proactivity loss, and the Netherlands and Denmark were examples of countries that provided a detailed explanation or information about the costs that should be included as part of societal perspective. And for example, the Netherlands recommend including time spent, alternative treatment, as well as consequences for sectors other than healthcare. And the last option was recommending both societal and healthcare sector perspectives as two separate reference cases. And here only 3 countries made this recommendation, which are Spain, Indonesia, and Thailand. And this makes 6% of the reviewed countries. So to sum, most of the reviewed countries recommended either a healthcare sector perspective or a payer perspective, and only 28% recommend either a societal perspective or both societal and healthcare sector perspective as 2 reference cases. So to conclude, most of the non-governmental recommendations advise on using a wider perspective, as for example, societal perspective or multi-sectoral perspective, while the majority of governmental recommendations tend to be narrower in their scope of analysis. And in 72 of the reviewed countries, the recommended perspective was either healthcare sector perspective or a payer perspective. And that's all what I wanted to present, and I will just hand off to the experts. Thank you.
All right, I'm David Kim from Tufts Medical Center, and thanks for organizing this wonderful symposiums, and thanks, Natalia, for a wonderful international summary. So I'm very grateful for these opportunities to discuss one of the most important yet often underappreciated issues in cost-effective analysis, which is analytic perspective. So today's presentations, I'm gonna focus on the second panel's deliberations and recommendations, but from analyst perspective, how we can actually take their recommendations into practice using some of the practical suggestions that the second panel actually made. So full disclosure is that I was not a member of second panel. There are like several second panel members and original panel members actually in the presence. I was very blessed and fortunate to be involved in that process as a student to develop the worked example to reflect their guidelines and then make it into the analysis. So I try my best to convey second panel's deliberations and recommendations based on my experience and my understanding. And some of the analytic work that I'm going to show you is supported by the Pharma Foundation Center grants to our center at Tufts. So let's start with the original panel that we all know that they made the seminal contributions to this field. And then one of the key contributions of original panel is really to come up with the reference case analysis to improve not just the quality, but also make sure the comparability across the different CEA is conducted. And as part of the reference case analysis, the original panel recommended to put the emphasis on the quality as a health outcome measures, but also they recommended a societal perspective as an analytic perspective. So let's take a little deeper look on what was the rationale actually of the original panel. So they basically ask these questions that when decisions made, we have to think about who is affected and on whose behalf are decisions made. Original panel clearly say answers to these important questions define analytic perspective. And then they go on and says, the societal perspective consider everyone affected by interventions, counts all significant health outcomes and costs that flow from it, regardless of who actually experiences the outcome or cost. And then they further define it that societal perspective is the appropriate one for decision-making concerning the healthcare resources in the public interest. So original panel made some normative judgment that whose benefits and whose cost should be considered by decision makers, but we probably agree on the underlying principle of the importance of societal perspective. Then the next important question is that, hey, whether analysts actually follow their guidelines. So let's take a look on the data. So this is analysis of our Tufts CA registry data. So there are about like 7,000 studies conducted since the 1974. We can identify information about analytic perspective. So let's first focus on the analytic perspective stated by authors, and this is the distributions. So across all studies, all 7,000 studies, about 27% of studies are conducted from societal perspective. But also the one thing to note that 20% of studies didn't really clearly say what are their like analytic perspective, which is surprising. So in order to be included in our registry, reviewers actually closely review what they actually said and they make sure that analytic perspective correctly identified. So if you look at those corrected analytic perspective, still about 1/4 of studies conducted from societal perspective, majority of studies conducted from healthcare sector or payer perspective. So someone can ask that, okay, is there any like time trends on this behavior? So let's take a look at that as well. So this is the number of cost per quality studies published. So as you see here, there are exponentially increases over time. Let's look at the proportion of analytic perspective in each year. So if you look at the societal perspective, there is a slowly going up, a little bit going down over time. And then as you know, in 1996, this is when the original panel actually came out with the recommendations for societal perspective. So it just, after that publication came out, slightly increases in terms of number of studies conducted from societal perspective. Around like 2006-07, it's just going back, and now it's about like 20% of studies. And not surprisingly, the health CEAs from healthcare sector perspective has the opposite patterns. And then here comes 2016, actually second panel came out with the recommendations. So what are some experience since the original panels that, as you've seen here, there are like many cost-effective analyses has been conducted, but most of studies actually not implying the societal perspective. And even when actually author says, I conducted study from societal perspective, the important elements often omitted. They just throw in the productivity benefits and they say, hey, we do CA from societal perspective. That was not the original intentions of the original panel, right? It really, you have to consider all those important consequences outside of the healthcare sectors, regardless of who gains and who lost. But practice has not really like that. And I think that Natalia summarized very well that decision makers actually using CEAs into their decision-making process, they often have taken more focused, narrow healthcare sector or payer perspective. And one of the prominent examples that NICE is NHS perspective. So second panel actually debates a lot about these questions. Does the societal perspective really make sense? And there is panel members who are against it. And then I'm not going to name the name, but their argument is that, if there is like no like societal budget, then how we are going to explicitly quantify opportunity cost lost? And then some argue that what is the societal perspective? Like, is there any like single societal perspective, or there's like multiple societal perspective depending on like what outcomes you're interested? And then, as you see, revealed preference of decision makers. But also there are other members of the panel, really, for the societal perspective. They said, but it is very important to capture spillover effect of medical interventions, not just on the healthcare sector, but also outside of healthcare sector. It is consequences of reimbursing medical intervention. And then a little bit normative judgment, but elected officers should know the potential consequences not on the healthcare sector, but also broader societal non-healthcare sector as well. And then particularly in the US, there is no like defined health budget, which is hard to make a healthcare sector perspective, but also issues with consistency with the original panel's recommendations and how we are going to compare analyses following second panel's recommendations and original panel's recommendation. So here comes the second panel, and as you know and heard, they recommended to two reference case analyses, one from healthcare sector and one from a societal perspective. But the missing point is that second panel just did not like walk away by saying, hey, analyst, you should do this multiple perspective and you will figure it out. They really didn't do that. They actually thought very hard, think very deliberately, and what are some practical tools that help analysts to think about these issues. So there are like two major recommendations. One is having impact inventory. I really hope that by the time now, you're familiar, at least you heard about this impact inventory. Often not as much as discussed is really the recommendations to report disaggregate outcomes. So this is really important, and I'm gonna give you specific examples about how to carry this forward based on their recommendation. So let's take a look first on the impact inventory table. So impact inventory really listing not just the health, but also potentially non-health impact. This is the framework for organizing, but not just organizing, but also really help analysts to think about what are the potential consequences of the interventions that you like to evaluate. And then presenting consequences of your thought exercise in the transparent manner. And the purpose of impact inventory to ensure that all broad consequences are considered regularly and comprehensively. So the way it's structured is that column shows that different sectors, types of impact, and a checklist for inclusions or exclusion, and also you can provide some notes. And then horizontally, sections divided into formal healthcare sector, informal healthcare sector, and non-healthcare sector. So I'm gonna give you specific examples that I've actually used for publication. So this is my recent publications based on look at the cost effectiveness of nutrition policies on processed meat. And then we did a modeling exercise to look at the implications for cancer burden. So this is the appendix table that I've actually published. And then this is the impact inventory that I've used. So if you focus on the health outcome side, that I measure health outcomes in the life years and also quality of just life year, both included from healthcare sector and societal perspective. And I also measure years living with cancer as separate health outcomes. And look at the fourth column that I listed spillover effect of a health-related quality of life on the cancer patient's caregiver. I thought that's important consequences of reducing cancer burden, so I listed that. But basically, I was not able to include it in my analysis because I was not able to find appropriate data to do it. But by doing so, I acknowledge that these consequences potentially important, and I make sure that I did not include in my analysis. Same for the medical cost, I included the third-party payer, out-of-pocket cost, future both related and unrelated medical costs called background medical cost. If you look at the informal healthcare sector, I did include the patient time cost associated with the receiving care, but I also listed unpaid caregiver time cost, transportation cost has potential consequences of reducing cancer burden, but I was not able to find appropriate data, so I did not include it in my analysis. Let's look at the broader the non-healthcare sector. So I did include the productivity benefits in terms of extra earnings by reducing cancer burden. Uncompensated household productions are potentially important consequences, no data available. What about the future consumption cost? I did not include, but I provide the rationale, so see the footnote. Basically, in that model, we assume that reductions in processed meat consumption does not confer any survivor benefit. So the impact of excluding the future consumption cost unrelated to health was negligible in our model. So this is how I actually carry out those. I took the impact inventory table and then make it to relevant to my study. And a second practical tool is that they actually do recommend to report disaggregate outcomes. The purpose is really to inform the decision makers or readers through the explicit quantifications and valuations, not just the health impacts, but also non-health impacts. And the second panel do recommend to include the intermediate health outcomes, such as the case averted, and also divided it into specific cost categories. And by doing so, it really helped not just the comparing results with the other analyses that may just use the intermediate outcomes, but also it really helped to analysis conducted from other perspective or the decision makers who may like to select specific outcomes of interest. So this is the example again. So this is actually my part of the main table included in the journal publication. And then this is basically comparing the two different policy scenarios. One is the taxes on the processed meat product, other one putting the warning label compared to the no policy. But basically, I reported my modeled outcome first as the overall health outcome measures, in measures in the life years and quality adjusted life years. And I do also reported the cancer-specific outcomes, such as cancer cases averted, cancer death averted, person years reduced. Cost also divided into the intervention cost, healthcare cost saved, and then time cost saved, and finally the productivity benefits to the larger society. And finally, I provided the aggregate summary measures using ICERs, one from a healthcare sector perspective and one from a societal perspective. So the second panel has actually provided these wonderful tools really to help, not just to burden analysts, but really to help analysts to think about these important issues. But obviously, challenges remained. A key challenge is that trade-off between the comparability and the flexibility. The goal of a reference case analysis is really to improve the comparability across different studies, but also we do acknowledge that decision makers may have a different preferences, so the guideline have some flexibility to reflect decision makers' preference. And then multiple reference case and impact inventory potentially or may create practitioner burden, challenges in publications, which I personally do not see as a big barrier, and also accessibility of findings, that if you have a lot of numbers from healthcare sectors and a societal perspective, then there are tons of information that readers or decision makers may need to digest, and how you're gonna handle that. And finally, a little bit on the more detailed methodological side, but how to value non-health effect and then effects on others, like spillover effect. I think that Scott is gonna touch on these issues as well. So I'm gonna end my presentations with some of the points that often get lost. Second panel actually did say, if you have a specific decision maker in mind, please do conduct a CEA from their perspective. So in my worked example included in the second panel's report, I actually did from a three perspective. One is from patient, one is from healthcare sector, and one is from societal perspective. And more broader issues that, as you may know, that in the decision-making process, cost effectiveness itself is really, one element among the many other important factors, such as equity issues, distributional concerns, political feasibility, and then affordability. So, and my final suggestion for the analysts, that analysts should be transparent about which items are included and how they are measures and values with a clear rationale. This is really gonna help the economic evidence that we generated as an analyst to be really clearly used in the decision-making process. Thank you.
Thank you. My name is Scott Gross. I live in Atlanta, Georgia. I'm here representing myself. And I have no slides. So thank you to the organizers, the Torbjörn and Yao Shin. And also thank you for the preceding presentations, which I'm going to draw on. I decided to focus on and elaborate on the perspective issues. And my subtitle is, "The Devil is in the Details." That's an idiom that on the surface, something may appear simple and straightforward, but once you get into the details, into the weeds, things can get very complicated. It's really important to address all those details. I salute what the second panel did with the impact inventory and the worked examples. Those are really, really helpful. It's hard, though. Many people don't pay close attention to the details. And as someone who reviews a lot of manuscripts, I get frustrated when people don't follow the guidelines. But also it's because the terms are confusing. We talk about the payer perspective and the societal perspective. There is no such thing as the societal perspective or the payer perspective. There's a payer perspective and a societal perspective. I mean, that's consistent with what we just heard. But this is really important because I see it all the time. Our analysis followed the payer perspective. Now, that in some countries where you have a single payer healthcare system, the payer perspective is fairly straightforward. It's roughly equivalent to the healthcare sector perspective. In this country and a number of other countries, it's not. Where you have a fragmented healthcare system, the payer perspective is the perspective of a particular payer or health system. You cannot aggregate across payers to come up with a payer perspective. That is the healthcare sector perspective. And I frequently see those terms used interchangeably. They are not. This is really important, particularly when it comes to prevention or curative therapies. In the United States, roughly 20% of members of private health plans change plans every year. That means that if a particular payer pays for a curative treatment where the expectation is you're going to be avoiding costs 10, 20 years into the future, the payer who paid for the treatment doesn't reap the majority of the benefits. And so payers, this is a real issue as we're coming out with now with gene therapies, the issue of HCV treatment. There's underinvestment in these curative therapies because, in large part, because the payers cannot expect to reap the benefits. It may be highly cost-effective, cost-saving from a societal or healthcare sector perspective, but that doesn't translate into the payer perspective. There have been a number of recent articles which have talked about that. The healthcare sector perspective is straightforward. That's generally estimates are comparable. One source of confusion is when people call it a healthcare system perspective. I very recently read a manuscript, a systematic review, where they had used healthcare system, healthcare sector, and payer perspective equivalently. When a U.S. analysis said we used the healthcare system perspective, they thought, the reviewers who were not in the United States thought that was a payer perspective, when it's not. So it's really important to use consistent terminology. I'm very glad that the healthcare sector term has displaced the healthcare system in most usage. The payer perspective can be really useful, but if you think about it from a healthcare payer, if they're not in the United States, the healthcare payer perspective may actually be the budget impact perspective because they're not necessarily interested in long term. So budget impact analysis, typically no more than a 5-year time horizon, and the focus is on the direct financial costs. That is a payer perspective analysis. It may not be what we want to do as cost-effective analysts, but that may be what that decision maker wants. Now, other payers may very much be interested in QALYs and interested in a long-term perspective. But you have to consult with your stakeholders. Different stakeholders will have different perspectives. Moving on to the societal perspective, or a societal perspective, the heterogeneity is extraordinary. One of the conclusions is that societal perspective estimates are very difficult to compare across studies. Healthcare sector estimates are much less variable than societal perspective estimates. So the transferability issue, as well as comparability, is seriously problematic. I'm going to focus on two particular methodological issues in the societal perspective. One is productivity costs, and the other is informal care time costs. And those two are sometimes confused. They are very distinct issues. The first panel and the second panel appropriately classify the cost of informal care as a direct cost, because whether care that is provided is paid or unpaid, it's still comparable from an economic perspective. Where the confusion arises is that informal care time costs have often been estimated as the opportunity cost of the time of the caregiver in terms of foregone market earnings, hence a productivity cost. But conceptually, it's not a productivity cost, it's a direct cost of care. There's the other issue, which is why would you use, well, actually, I'll get back to informal care. I'm going to start with productivity costs. Productivity costs are also distinct from patient time cost. Productivity cost refers to the loss of economic production associated with sickness, disability, or premature death. There is no consistency across the CA guidelines as to whether societal perspective analyses should include productivity costs or not. The first panel said there is insufficient basis to include productivity costs, unlike informal care time costs. The second panel does authorize or encourage the inclusion on condition that future consumption costs are also included. I mean, if I see Anirban sort of shaking his head, he can clarify that. My reading of the second panel is they recommend both future consumption costs and productivity costs. And so I would say if you include one, you should include the other. That's important because the majority of productivity costs, when someone is earning money, if they're not earning money, there's also not going to be the consumption costs well, it depends. For valuing mortality, avoiding mortality, you lose that earning that someone would have made, but you also lose that consumption. And so the reduced consumption will offset much of the lost productivity. That's why it's important to include both. If you subtract the cost, the productivity benefit, and you don't adjust for the reduction in consumption, that's asymmetrical. So I think that was logically consistent for the second panel to include both. I've not seen any other guideline which has done that. I think that's very distinctive, a really important conceptual advance. I think the details of how to do that remain to be determined. I've already talked with David about this. But that's a huge step forward. But the productivity costs, how do you estimate productivity costs? In the United States, the human capital approach is traditional. In some European countries, Australia, Canada, the friction cost method is recommended. Friction cost focuses on the short-term costs of disruption to the employment. It's really from the employer perspective. What is the lost productivity? Because someone is sick, cannot work until permanent disability or death, until that worker can be replaced. That's the friction cost. Human capital, there is no cap. If someone dies, the entire stream of future earnings, as well as any outside non-market productivity, is included. So you can get a 10-fold or even 20-fold higher cost of productivity using the human capital approach compared to the friction cost approach. It varies depending upon the condition. I co-authored a review article on that topic if anyone's interested. The absenteeism and presenteeism is often used as meaning productivity costs. That's a subset. When someone has a condition that prevents them from working or requires them to take an occupation which is much less remunerative, that's neither absenteeism nor presenteeism. So it's important, if you're going to include productivity costs, to be comprehensive. Informal care. The informal care is recommended, but as we just saw from the worked example that David presented, it's typically not included. Even when people are diligent in following the impact inventory, because lack of data, or people make the argument, in this condition, we don't think informal care is a sufficient issue that would influence results. Those are the two reasons. If you don't have data, or if you think it's not going to affect the results substantively, you can leave it out. But outside of dementia, most cost-effectiveness analyses have not included informal care. Inclusion of informal care time is appropriate, but there's no consensus or consistency in how you measure the informal care time or how you value it. As I mentioned, one approach is to look at how many hours are lost from paid work. If a parent stays home, usually a mom, you value her time as how much lost work, and then you take an average wage. Which wage to use, that's another issue. What about the other time? Leisure, sleep, personal care? That implies no value on any of those time costs. And there was an article in the recent issue of Pharmacoeconomics, which Lisa and Eve Wittenberg were guest editors on. I encourage anyone who's interested in this, it's a comprehensive approach at spillover effects, looking at both spillover effects on family members' utilities and on care costs. The valuing the informal care time should be done in a consistent manner. If you only have estimates of the loss of paid work, that may be one approach, but it's a limitation. Now, it's hard to measure informal care because suppose you have a child who has a neurological disorder, how do you know how many hours of care that child requires because they had the condition, since children receive care anyway? It's that incremental care time which is important to estimate, and that's very challenging. Then how do you value that? Do you apply an average wage in the economy? Do you try to estimate the opportunity cost of the particular parents or group of parents? Lots of methodological issues. So I think I'm going to end there. I'll end early, which allows more time for discussion. Thank you.
Wrong slides. Good.
So good afternoon. My name is Yaoxuan Chen. I work in vaccine modeling team at Merck. Just kind of take a step back from what we hear. And I want to actually share with you about not what to include, but how to make it happen. Because as an engineer by training, I tend to think how to do it so that it can happen. And when it comes to decision problem, sometimes there are two steps. One step is to figure out the problem. It's 3 steps. Second step is to debate what to include in the problem. And third step is to make it happen. I'm an engineering by training, and to me, MCDA is kind of in that last last stage phase is how to make all this wonderful discussion be transparently incorporated and come up with a solution. So this is a motivational speech for MCDA, so please don't look for details, how to do it now, this time, but I see so many wonderful analysis in the back of the room, so please feel free to grab one of us to ask more about MCDA after this talk. I include this one as just an example of trying to attempt to summarize what we hear so far is we debate about what costs to include. How do we measure the improvement of health outcomes in the process? So in that discussion, I see that there is a point to be made in this cost-effectiveness plan where on the x-axis, it's the measurement of the differences of the health impact. On the y-axis is the difference of the cost of two policies of consideration, two only. So what have been discussed? What will, if we do really change or modify our decision in the way, what really make an impact here is that dot will move as a result of which perspective we choose, what cost we include, whether we consider certain outcomes or not. As we know, two policies, the main impact after this care deliberation is moving that dot along the plan. And a lot of audience here learn to kind of do decision analysis in this way. We come out with willingness to pay threshold, and then we compare that threshold with that dot of two policy points to say, okay, if that threshold is actually below or above the threshold value we choose, then we take an action. We say we choose B or not choose B in terms of policy, between policy A and B. But as we have heard so far, the guidelines of how to choose this threshold value, what perspective to include or not include, what kind of costs should we pursue or not, are still evolving. So that's actually, I try to use this simple example to summarize a picture of what we have seen so far. This is one way I've seen how analysis being done in the health economics field. And there's another approach that people may be more familiar with, is the tabular approach, where we basically specifically lay out what is the cost for each policy we concern, and what will be the improvement or healthcare outcome of concern. And then we say, okay, let's look at the payer's ICER, let's look at the society ICER, what the value it is, and let's look at the method one, which gives us a specific threshold value. Method two gives us two. Then we compare this ICER value with the threshold, and we make a clear decision saying, okay, we are not going to adopt A or B because of this comparison result. This is a second approach to come to a decision in the field that we are in the field that I recently came into. What I try to actually, the reason why I put out that two approach is that I want to encourage audience to think about the decision process is actually an optimization problem at the heart of it itself. If we could actually well define the decision in an abstract manner, and then we take our time to debate what to include, not to include, to determine the parameters that will go into a decision problems. And we work with optimization experts to sit down and ask them, go with them step by step to write down what is the objective functions that all the debate has been ongoing, and what are the constraints that actually embedded in the discussion that has been ongoing. I don't think I'm going to go into all these details of the formulation, but this is basically a typical optimization problem that describes the same problem that you have seen earlier with these two approaches: graphical approach, tabular approach. This is an abstract way to describe the decision problem where there's a very fine structural manner embedded, which is objective functions and then constraint sets, so that the decision you have to be made by solving this problem, you will be able to get the decision that you need. So in these three type of approach that I have laid out, which method should be preferred? It actually comes to the same conclusion if you use problem A and B and C. Which method should you prefer? My answer to it, after working in the government agency with health policymakers, after working in the industry with clinicians making the decision of how to invest, my honest answer, and my background is optimization by training, I will come to the conclusion is it depends. It depends what's the objective of your conversation is, and it depends what kind of problem in the real life you really want to solve. I like that approach, but these two help me so much to open the door for me to popularize the very difficult approach that's usually abstract, but it's powerful to scale up your problem, examine thousands of options, and using machine learning algorithm to get the problem solved. That's the ultimate way of solving things in the most efficient manner, but I cannot communicate that in plain language with policymakers. Unless I use the first approach, I teach them carefully about what first approach really means. And if they prefer the second approach, I'll do that one too. The reason why actually in this setting, why we would like to actually talk about multiple criteria decision analysis is, in my mind, it actually is another form of optimization problems where we can clearly combine different perspective, different discussion point in a very transparent and traceable manner. You may not understand what my notation there is just by looking at it, but I can assure you, if you sit down with me 30 minutes, I'm happy to correct it if I'm wrong. I'm happy to change it if I made a mistake. But you will agree with me what changes to be made in order to reflect your true concerns in your mind. And there have been two wonderful report, I would say high-level discussion about MCDA's use in the pharmacoeconomics field. And I will recommend you to take a look at it. But the point is that the framework of optimization itself allowed us to combine a lot of concerns into a very clear format, objective function and constraints. That's it. And the development methodology can just help us solve it. We don't need to invent any new wheel. The reason why actually I want to point out the real strength of MCDA is not because it's just beautiful in mathematically speaking, but it's actually important in making something possible in the real world. Because what I have seen so far is this is a very abstract diagram to show you who are the players in the whole process when a policy comes to become a guidance until it touch the life that it's supposed to touch. There are actually two abstract phases that second phase is usually neglected, which is the implementation phase. When a guidance is formed, how that guidance is actually implemented is another thing. But I see too often that we stop short at the policy implementation side. We look at the guidance formation. We take too much care in the higher level concerns. And as a result, a lot of time the implementation is done differently from what the guidance is meant for. I think MCDA is actually one of the methods that could help us directly address those issues that we often face in the implementation phase. not just the guidance formation. A lot of times in the implementation phase, we will come up with issues like equality issues, budget constraints, resource availabilities, personal scheduling feasibility. Those are the real constraint from those healthcare providers that who will really execute the, say, the vaccination policy guidance that has been put out. Their concerns are equally important than this cost-effectiveness debates that we hear so far. This kind of framework allowed us to incorporate them into the decision problems, and then it can be solved. And gave us a solution where those constraints actually is taken care of at the same time. So it's no longer two-stage problem. We come out with a guidance and let's implement it and try to solve it to see how we shape the guidance. In the guidance phase, we could have taken the whole pictures and then solve it to come up with a policy that addressed those questions from the very beginning. If anyone is interested in looking at some literature, some review on the multiple criteria decision making, I also put a reference there. One example that I recently see and thought that MCDA could have helped prevent it is back in May, PHE, Public Health England, actually noticed that there is a huge problem in HPV screening guidance they provided, because they encourage everybody to get HPV screening, while at the same time, the laboratory around England was closing down because of the budget constraint. As a result, a lot of women went to the clinic to get HPV testing, but they couldn't hear back their HPV result for more than 3 months. The problem has been solved now, but this is one example I would like to point out that we have two-phase problems. First stage is equally as important as the second stage. Despite its own usefulness, complexity of doing it make it very vulnerable to implementation errors and resistant from decision makers in real life. Every part of it in this problem that I highlighted means we need to figure out what the data should be. What is the right way of combining different objectives? How we actually come up with priority weights to evaluate between different conflicting objectives. Those things bring fuzziness of the real problem into the real problem. And this is what makes MCDA weak, despite of its complexity. I honestly say that a model is as good as its data. If we cannot get good data, we cannot come up with a trustworthy solution. So my talk, the summary is that the approach that we seen earlier are much simpler to understand. It helps us to reach conclusion with swift, clear authority, but at the cost of oversimplifying the implementation process itself. MCDA, I would say, it really provides a more democratic, rigorous, and efficient framework to inform decision from various perspectives. And I would really want to pound down that if you work with anyone, please have them make long-term commitment for this approach, because it can never be done once and then put on the shelf. It has to be constantly involved and improved in order to make this MCDA toolbox that we develop truly useful to the problem we solve. So that's actually what I have in mind to talk about today. And I want to thank these two wonderful colleagues, Dr. John Cook and Elming and Barsha from Merck, helped me to transition from optimization technicians into to learn some interesting discussion in the healthcare economic fields. And if there's anything unclear, it's my fault. So feel free to ask questions.
Yes. And I will thank all the speakers, and I will open up for discussion.
Hi, my name is Sadia. I'm from University of Toronto. I can't tell you how much I appreciate this symposium, in particular because my project, which I presented at the Libby Lusted yesterday, was on how analytic perspective matters for my project on early intervention in psychosis. And a special thanks to David Kim. Your worked example was what I used to help write up my manuscript. So thank you for that. Two things that a piece of feedback that I got on my project that I think is relevant for this discussion is when it comes to things like when I'm considering a societal perspective, and the hope is that, for example, early intervention psychosis will result in more people with psychotic illnesses having employment as opposed to standard care. One piece of feedback I got is, how is that good from a societal perspective? It's taking jobs from other people. Another piece of feedback that I got was that, actually, I'm blanking on what the second piece was, so maybe I'll come back to it. Let me just think for a second. So much pressure when you're in front of everyone on a microphone. You know what? I'll come back to it. I'll let someone else go before me. Sorry, that's really awkward.
So is there any specific questions or
The specific question that I got was, like, if you're supporting someone with a mental illness getting a job, one piece of feedback that I got was, what if the impact of taking away from someone else's opportunity for a job?
Yeah, all right, so I think...
Okay, that's really the friction cost perspective. The assumption is that there's a large number of unemployed or underemployed skilled workers.
Yeah.
Whether that's a realistic assumption is unclear.
Right. And actually, I do remember now what the second piece was, and it was actually, Scott, you and I talked about it at my poster yesterday, which was that, is it appropriate for me to assume, because I'm including productivity benefits, I'm including wages, average wages, et cetera, for those with psychosis, is it appropriate for me to assume that they can work, is one piece of feedback that I got as well. Because my concern is if I don't assume that, that is also discriminatory. And, I could see both sides of the conversation around that assumption of the ability to work with a severe mental illness.
Right. Well, yes, you were focused on absenteeism and presenteeism, which is consistent with the short-term friction cost approach.
Yeah.
So I don't think whoever raised the first question, that wasn't a problem with your analysis.
Yeah, that is true. And that is what I told them. But I was just curious what your thoughts were on that,
if
too.
you had followed a human capital approach, the bulk of the productivity cost would probably be because people with psychosis are completely out of the labor force. That loss in production is a real cost, in my opinion.
Yeah, I think that in the worked example that I've done to look at the impact on the patient with alcohol use disorder, because we discussed that alcohol use disorder is a severe disease enough to people whether they really going to contribute to the workforce or not at the external margin. So in terms of data, we actually use that a probability of proportions of people who formally participates in the labor market, and then depending on the health states, I use that as to quantify productivity impact. So I think if you think that whether at the external margin that whether your disease is severely impacted, actually going back to job force or not, I think that way probably reasonable approach. If there's a more minor disease like migraine, that it's not really going to impact on the external margin, but more, whether they're gonna work like how long extra hours. That gives going back to more like you can precisely measure productivity using absenteeism or presenteeism.
Thank you so much.
Milton Weinstein from Boston. This is bringing back memories from the first panel and before that even. My question, which has always troubled me, and I'm curious from you and the panel and the audience, what the current thinking is, has to do with thresholds for ICERs. And I apologize, I'm talking about cost effectiveness analysis, not MCDA. But if you're going to construct an ICER, depending on the perspective you use, shouldn't use a different threshold? And people glibly talk about, 100,000 per QALY in the US, but surely that threshold can't apply simultaneously to all of the perspectives that Natalia so nicely laid out at the beginning. The payer perspective, the healthcare sector perspective, ortho-societal perspective, all the different flavors of societal perspective, depending on what's in and what's out. Just wonder what the current thinking is, starting with the panel and anyone else in the audience who has some thoughts on that.
I'll take first cut at that. I would say it's not the job of the analyst to decide what's the appropriate threshold.
I agree with that.
Or whether something's cost effective. That's for the stakeholders to determine. And so it's appropriate to calculate the range of ICERs from each perspective and then defer to the decision makers.
Inevitably, authors of papers will comment on that, if only for the purpose of doing sensitivity analyses. You say at a threshold of 100,000, the efficacy has to be at least X in order to make it cost effective. So you end up finding, whether even people like me who don't like to propose thresholds, you end up mentioning them. And the question is, shouldn't it depend which perspective you're using, which thresholds you mention?
Yes.
Yeah, all right. I just wondered if there's any current thinking about that.
Yeah, I will let Honorban respond to. Or your questions, or are you responding to?
Well, I was going to say my question is just a kind of version of Milt's question, which is a good microcosm for my career. So this summer, I spent 2 months at York drinking warm, flat beers with people like Carl Claxton and the like. And the idea of opportunity cost thresholds came up a lot. So at York, they estimated this opportunity cost threshold of 13,000 pounds per QALY for the healthcare system. They also estimated an opportunity cost threshold of 5,000 pounds for the public health unit. So not healthcare, but public health. These are two separate silos. So then one interpretation or extension of that is if there's an intervention that has costs both in the public health budget and the healthcare budget, is a pound, because you could it only takes 5,000 pounds to create a QALY in the public health space, where it takes 13,000 pounds to create a QALY in the healthcare system. So is $1 is my general question.
$1 is always $1, wherever you go. I think Milt's point is right on target, is that you need to have different thresholds for different perspective. I would only say from the US, we use 50,000 to 150,000 all the time. ICER, the other ICER organization, uses it. If you look at the history of where those estimates come, none of them is a healthcare system threshold. It's everything points to the fact it's a societal threshold. And yet, if you see how we use those thresholds, just do the analysis from a healthcare sector perspective, which should have, in principle, a higher threshold, and compare it to those thresholds that are societal thresholds. So just to be consistent, it seems, at least in this country, we should be actually doing a societal perspective analysis to even compare to those thresholds that we traditionally use.
Yeah, it's not like responding to Honorban's comments, but I can speak to what ICER is doing currently in the US. So for those who are not familiar with ICER, ICER is kind of like similar institutions to like NICE in the UK. It's not like government endorsed agency, but they do have a technology assessment, and then they provided this economic value, and then they provide a value-based price. But one thing that I related to perspective that in the 2 years ago, when ICERs actually revised their value framework guidelines, they actually endorsed the multiple perspective for a particular disease. So basically what they're doing when they conducted analysis, in the base case analysis, it's from healthcare sector perspective, but in a specific case, such as a rare disease or the targeted for the early childhood, they actually alleviate the societal perspective into like core-based case analysis. And then they consider ICERs from both healthcare sector and societal perspective into their decision-making. Their decision-making process, they're not using explicitly cost-effective thresholds. They use the range of cost-effective thresholds. So it value falls between like 50K to 150K, then they said it's a reasonably good value. If the value goes over 150K, actually the panel member, they do have like voting committee. So they share all the information, and then voting committee actually vote on this drug is really good value or not. And then one recent example is they actually look at, there was a drug to treat the inheritable genetic eye disease. So it actually impacted hugely on the early childhood because you improve the visions for early childhood. There's a huge impact on education and other things. So for that cases, the ICER was a very, very high. Like I don't remember exactly, very close to 500K from healthcare sector perspective. Even though you added the other value, like educational benefit, productivity benefit, it's close to like 300K per quality adjust life year. But when they actually vote on this drug actually good value or not, ICER voting committee, like there are like 12 to 14 members, actually said this is good value because of this is a first-in-class drug. It's targeted, it's for the rare disease, target for early child without no treatment. So even though ICER itself probably considered not cost-effective based on the conventional cost-effect threshold, they do consider these other contextual factors and then say still this drug can be good value. So this is what currently ICER is doing, not just using explicit thresholds, but considering a lot of other factors into decision-making process.
I want to come back to a question which all of us, including myself, don't like. What is your experience, having looked through the CA registry data, about how people deal with the fact that some of these cost data are missing? And you showed in your example very nicely, you have that column, and you just ignore the costs, and you put in no data available. In fact, you make a very strong assumption setting these costs to zero, which in most cases we know that assumption is completely wrong. So wouldn't it be better then to assume some costs, even they are very vague? And I'm thinking about that in the base case, not just in some sensitivity analysis. And linking to the question about the ICER, now let's assume we even have an ICER in a country for the level 1 perspective, level 2 or 3, and then if you have some of these missing data, you're sort of in between these levels, like level 1.5. But the question is really how people dealt with that, not the solution, how should you, but how people dealt with that. I assume most did it like in the example you have shown, but I have no idea how that is.
So that's a great question, then. From my work example or the papers that I've shown, really, to be honest, I struggle a lot to identify these data that, the second panel listed all those, potential impact, asked me to quantify it as an analyst, then I really spent a lot of time to dig into it. And whenever I have at least reliable data that I can make extrapolation or at least or to build the distributions around it, I try to incorporate it. But for example, informal household productions, to me, like there was two issues. First, how you're going to measure it. So is there any data to measure informal household productions? And second thing is how we're going to value it. I think the second part, we can come up with a certain number. We can use the average wage data, but if it's a missing on the first part, that there's like no measured data on certain outcomes, yes, that's true. We can like make the assumptions, but basically my prior information was just the two non-informative priors to make that judgment. So I better just say that, okay, I think about it, but no data available. But it's clear important issues in this field, and future directions papers put out by the second panel clearly listed those having more standardized cost catalog to document these important cost components as one of the major next steps. So hopefully we have some opportunities to work on that.
One thing you could do, of course, is as long as you use Monte Carlo simulations and incorporate a lot of uncertainty around this, you could kind of set upper and lower bounds to these costs and include them and see whether it affects the conclusion of the analysis. So sometimes you have some kind of expert that knows the ballpark or could guess something around the ballpark, and then I don't know.
So I will. So, yeah. So I will add one additional comment to Uwe's question, which is that there are efforts to create scoring systems that predict the number of caregiving hours to the EQ5D, so to different levels of the EQ5D. So there's one example of that in the special issue that Scott mentioned. I hesitate to talk about a competing journal. It's in pharmacoeconomics. It's not being recorded. But there are efforts underway to do that so that there would be a standardized set of at least an approximate number of caregiving hours that you could generate if you had an EQ5D score or some other level of severity of illness. But I want to comment on the threshold question that Milt brought up, because that's exactly the right question to ask. And yes, we should have separate thresholds, and we conveniently get away from that here in the US just simply by saying, well, we don't have a set threshold, so we don't have to answer that question. But exactly. But and I completely agree with Anirban that the suggested thresholds that we do have that are rooted in some evidence are really grounded in a societal framework. And so those are really societal thresholds. But at the same time, it's important to recognize that those frameworks are, as far as I know, all individual frameworks. And so when we're talking about, for example, the special case of family spillover effects, and we're expanding the unit of intervention and benefits beyond an individual, we don't have any frameworks to really generate the thresholds there yet. And so that's an area of future research. And so for those of you looking for more research ideas, to think about that.
Hello, I'm Ken Smith from the University of Pittsburgh. We ran into a problem with an analysis that we did for CDC looking at vaccination recommendations, knowing that the underserved in the US have higher rates of pneumococcal disease but are vaccinated less. We found that if we did an analysis from a societal perspective, we would have to use different productivity costs for the underserved versus the general population. And that sort of forced us to not use societal perspective. I wanted to get the panel's views on that.
It's been standard practice in the US for decades to use the same productivity costs, regardless of race, ethnicity, or socioeconomic status, in order to avoid such issues.
So my question would be, is that a valid assumption to make, or a valid, so I certainly see the sort of ease of doing that, but in terms of that being in the spirit of the recommendations, not sure how that fits in.
My dissertation advisor at the University of Michigan raised that same comment after I left there and started doing work in public health economics. I understand from an economic perspective that is an issue, but as a public health perspective, the decision has been made to not do it that way because of the implications, issues of equity.
And from analyst perspective, if you think that the productivity impact is really strong and you have to quantify it, I probably, if I were you, I would quantify it using the average mean wage, just based on comparability issues as well. But also, if you strongly think that the target populations of your intervention is really underserved populations, they have a much lower mean wage than average wage, then I would just use that numbers as I quantify productive benefit using this. But because our target population is underserved populations, I use actually different wage to value that productivity benefits. Under that case, this is the result, and you can say at least that it made a huge impact or not much impact. So it gives additional information for decision makers to really think about this, rather than just, oh yeah, I don't like the assumptions, I'm not gonna do it.
Murray Meaning from the Netherlands. I'd like to just get back to the comment about the average wage. So I understand for the equity reasons, but then do we make them age and sex specific? Because then we'd get gender discrimination.
Yes.
So the first panel did recommend, Milt would remember, did recommend age and sex specific wage. We did not. We said, we just use the median wage for everybody.
So you don't even make them age
Nope.
specific? Okay.
No, we just use a simple average median wage of a society to use it, just to quantify that benefit. I think the distributional issue should be dealt outside of a cost effectiveness analysis. It shouldn't be tried to be, pigeonholed into an analysis which is meant to actually, address efficiency.
I would say that the existing published estimates of productivity for the United States are published by age and sex. Whether people choose to break it down in that way is up to the user. So the data have been made available for people to decide how to use it.
Are everyone now completely sure what to do when they perform? I hope at least that this session has helped this discussion a little bit, and I thank you all for coming and for participating.